Well, good morning. I'm Tim Sheehy, President of the Metropolitan Milwaukee Association of Commerce, and welcome to the Business of Metro Milwaukee. These webinars put a spotlight on the challenges and opportunities we face in sustaining and growing the region's prosperity. These insights are designed to help your business and to help inspire you to help shape the region's future. Today's program is sponsored by United Healthcare. United Healthcare is working with the MMAC to help make it easier for you to find a health plan that works for your employees and your bottom line. To date, we've added over 350 companies to this program. That's why when you work with an MMAC affiliated broker, you'll receive discounted rates on United Healthcare's All Savers alternate funding health plans. Plus, you have the option to add other United Healthcare plans to your employee benefit packages, such as specialty plans and supplemental financial protection plans for groups with as few as 5 employees. So to learn more, contact your MMAC broker or visit MMAC.org to learn more. Also, we want you to please consider joining us at the historic and revitalized Bradley Symphony Center Hall on November 30th for our 160th all-member meeting. Gain some great insights into the plans for addressing the region's challenges and investing in those assets that help us compete for capital investment and jobs. You'll also find it a great opportunity to network with other regional and business community leaders. So again, thank you for joining us this morning. And again, we're grateful to have Dr. John Raymond, President of the Medical College, to join us with an update on all things COVID. And then we'll have time to answer your individual questions. So Dr. Raymond, thank you again for joining us, and I'll turn it over to you.
Thanks so much, Tim. And before we get started, I'd like to acknowledge that this Thursday is Veterans Day, and to thank all of our veterans for everything that you do to keep our country safe. And also to say I've been a VA physician for 39 years, and it's provided me with some of the greatest joys and greatest honors of my career to work at the VA. So thank you so much. Tim, you know, we've been doing this now for 20 months. It's hard to believe.
Yes.
But I don't think any of us would have predicted at the beginning of the pandemic that we would still be dealing with such a significant problem. And it's also been an honor for me to work with you and the great leadership of the MMAC. So thank you. To put things in perspective, worldwide global cases of COVID-19 now have exceeded 250 million PCR documented cases, and we've had over 5 million deaths since the beginning of the pandemic. In the US, we've had 47 million cases with close to 775,000 deaths. So this has been a real challenge for us. On the other hand, I think in the good news category is in the US, we've had 223 million different individuals receive at least one dose of an authorized COVID-19 vaccine. So that's 68% of the population, and 193 million have completed a course, and that's 59% fully vaccinated. So we still have a long way to go, but I think we should also reflect on the great progress that we've made. So to start with the latest numbers, and these were mostly from yesterday, our trend in Wisconsin actually is no longer favorable. We have had a clear uptick in cases over the last week. Recall we were down close to a 7-day average of about 1,700, and now that's up close to 2,200. And this is actually not unusual. About a dozen or more states in the US have seen their progress stall, and in some cases look like it's beginning to reverse. Now, the 7-day averages can be significantly impacted by a single outlier day. So I don't want us to overinterpret that we're necessarily heading in the wrong direction, but this certainly bears watching by all of us and maybe some extra mitigation measures going forward. Also in the bad news category, our positivity by test is going up, and that is an unfavorable trend. At one point, we were down close to 7%, and now it's up to 8.9%. We really want that to be below 5%. So again, we still have some progress that needs to be made. And our R value, which had been hovering around 1 for the last 6 weeks, has been measurably above 1 for the last few days. It's been 1.1 or so since the end of last week. So again, a slightly unfavorable trend that bears watching. Yesterday, we were actually the 3rd worst case in terms of our 14-day delta or trend of new daily cases with an increase of 39%. I just looked at the New York Times data before we came on the webinar. And again, a single day's number can significantly impact these percent changes, but we're still in the worst 10 in terms of our trend as a state. Hospitalizations down 8%. So we do want to see more declines in the number of hospitalizations. But we're in the middle of the pack, maybe at the back of the middle of the pack compared to other states. And we are clearly in the middle of the pack for vaccinations at 59% fully vaccinated, which ranks us today as the 27th best state. Next slide, please. Hospitalizations and deaths, our daily average of deaths is flat. It's 14. It's been running anywhere from 12 to 14 for the last 6 weeks or so. Hospitalizations were going down significantly, but they have flattened out and maybe even gone up just a bit over the last few days at 995. ICU census in Wisconsin is flat. ICU occupancy is flat to unfavorable compared to last week at 92.7%. And our hospital bed occupancy is flat at 90%. And just in the interest of full disclosure, most of the people in ICUs and in the hospitals do not have COVID, but we do have a lot of pent-up demand for delayed and deferred care that is filling our hospitals. And with still a significant number of COVID-19 patients in the hospital, that strains the bed capacity of our hospitals. In addition now, after 18 months of working very, very hard to take care of patients with COVID and who do not have COVID, our healthcare workforce is exhausted, and the staffing remains the most significant limiting factor in being able to render good care to everyone. The trends here in Southeastern Wisconsin, maybe a little bit more favorable. We were on the leading edge of this Delta surge compared to the rest of the state. And we also were on the leading edge in terms of being the first to see a favorable trajectory. But like much of the rest of the state, and as I mentioned, about a dozen other states, things seem to be flattening out or turning unfavorable here in Milwaukee. And again, in full disclosure, we're talking about a limited data set over the last 7 to 10 days. And hopefully, if we continue to practice good mitigation measures, we can resume that favorable trend. Next slide, please. This is a picture that I like to show, showing the burden of disease in Wisconsin's 72 counties at 4 different points in time over the last year. Red is bad, dark blue is almost as bad, and lighter blue is more favorable in terms of case burdens in each of our counties. And you can see starting at the left last November, actually 51 weeks ago, we were really in serious trouble with critically high case burdens in most of our counties and very high in just a handful. As we started to vaccinate people in December, January, and February, we had a significant downward or favorable trend in the case counts in all of our counties. And then moving over to the third from the left, that picture there was in late June and early July. You can see we were in a very good place with the pandemic, with many of our counties with low case burden and most of the rest on the low end of the medium scale. But unfortunately, in July and August, the Delta surge hit us, and we're still experiencing that now. And as you can see on the right, we still have very high case burdens in 57 counties, critically high in 4. So not as bad as we had last November, but still a significant surge. And then 3 counties have a high burden. And interestingly enough, these are the counties either where there is a very high vaccination rate, which would be Dane County, or where this surge started in Wisconsin, which is Milwaukee County, as you can see on the right. So we were trending favorably, again, until the last 7 or so days, and that will bear some watching. The next slide, please. This shows you the trends, and again, it really depends on where you start and end if you decide whether we're trending favorably or unfavorably. And if you look at the circles for new confirmed cases on the top left, new probable cases in the middle, and the percent positivity by the test, if you start back a month or two, we look okay. But if you just look at the last 7 to 10 days, you can see a clear uptick in the number of new cases that are confirmed or probable, or the percent positivity by test. So again, I think that we really need to keep an eye on this for the next week or so to see whether this uptick is real or whether this is just a component of variability in this plateau that we've reached. Next slide, please. Thank you, Chris. Just to summarize some trends as of yesterday in the US and in Wisconsin, we are still experiencing the Delta surge, the 4th or 5th wave of COVID-19, depending on your community. And it is decreasing, but more slowly on average in the US than it had been over the last few months. The daily case counts have declined to about 72,000, and they've stayed there now for the last 5 or 6 days. And the trajectory over the last 14 days has been flat. Hospitalizations continue to decrease in the US, with about 47,000 in the hospital with COVID-19 after peaking at 100,000. But at least for the last 3 or 4 days, there's been a significant flattening. We're kind of stuck at 47,000. On the other hand, if you look back 2 weeks, we have had a decrease of 13% of hospitalizations in the last 14 days. Deaths also are dropping, but are still quite high. They've been at 1,220 for about 3 days, and they had peaked at over 2,000 about 6 weeks ago, and they've decreased by 19% over the last 14 days. I do want to emphasize that although we've made progress with the Delta surge in Wisconsin, and admittedly we stalled a little bit, we still have a very high case burden at over 530 per 100,000 population being diagnosed over the last 2 weeks, and there's been some leveling off. So when you think about gathering together for the holidays, moving indoors when it starts to be cold outside, or returning to work, just remember one of the variables that you have to take into consideration is the burden in the community. Wisconsin hospitals are full, as I mentioned, and some of the numbers there on the bottom. I point out that as of yesterday, we only had 99 open intensive care unit beds in the entire state of Wisconsin. Next slide, please. Now, I do want to remind people of the scientific process because it has been circumvented out of desperation, obviously, for us to try to find effective therapeutics for COVID-19. But I really have never explained this process to the audience, and I'd like to just take a minute or so to do that. In the typical scientific process, there are many steps. An individual or a group makes an observation, they generate a hypothesis, and then they test the hypothesis in test tubes, in animals, or in clinical trials. Then they try to confirm that, and usually an independent group or more than one independent group will also try to confirm. You refine your hypothesis, you retest, and then eventually you try to publish your work so that it can be verified by others. And that involves a very significant, heavily scrutinized peer review process before a group of work can be published in a reputable journal. Then other groups will try to confirm or refute those findings, and the process is refined. So the points here are science is an iterative process. As I mentioned, it starts with an observation, goes on to a hypothesis, then there's much testing and refinement, and then confirmation by independent groups. Science isn't static. It's based on the current state of knowledge at a given point in time, and our understanding evolves based on new evidence. And I think this has been particularly problematic during COVID-19 because there is a staggering amount of new information that we're all trying to process in real time almost every day. And when you think about publications and findings, remember that science is context specific. So when you think about vaccines or therapeutics, you do need to understand which population was studied, when, where, and which variants of COVID-19 were circulating at that time, so that you can make responsible conclusions about the work that was done. And there really are no shortcuts. If we can go to the next slide, I actually do want to talk about how the scientific process has been disrupted, derailed, and corrupted during the COVID-19 pandemic. Too frequently, people have made an observation, generated a hypothesis, and jumped immediately to public advocacy. And some examples are for drugs that people still believe in, actually, like chloroquine, hydroxychloroquine, zinc, azithromycin, and vitamin D. Nothing wrong with those drugs as candidate drugs because they're inexpensive, they're broadly available, and for the most part have been FDA approved for other reasons. But the problem is people jumped onto social media, began public relations campaigns, acquired political patronage, and individuals who really weren't as qualified as other scientists really were advocating for these drugs using the trappings of science, which really would be difficult for an educated lay audience to discern from people that really are trained as scientists. There was a lot of anecdotalism, a lot of slogans that were out there, name calling, and even mainstream media misinformation. And what I want to point out is about 15 years ago, as the economic model for media began to change and began to move to more digital platforms, a lot of media sources could no longer afford science writers. So the people that used to be in your local hometown newspapers, national publications, who could read science with a critical eye, could take a complex set of data and translate those into something easily understood by a lay audience, have really gone away. And so I want to make sure that people understand, as we think about therapeutics, as we think about vaccines, there's nothing wrong with repurposing old drugs. We really need to be looking into that, but we can't leap ahead of the scientific process. Next slide, please. Now, I just want to summarize what we know about the therapeutics for COVID-19 right now. Dexamethasone is a repurposed, inexpensive therapy that's broadly available. It's been widely used to prevent cytokine storm and to keep people with moderate COVID-19 disease from tipping over into severe disease that requires intensive care unit care. So there is an example of organized medicine embracing an inexpensive, repurposed therapeutic for COVID-19, and we've been using this since May of 2020. We also have monoclonal antibodies for mild disease that are modestly effective if given early. And the two products that are under emergency use authorization right now are the Lilly and the Regeneron product. And I do want to point out there was some exciting preliminary data released by Regeneron earlier this week that suggested that long-lasting prophylactic immunity could be obtained by a single subcutaneous injection of their monoclonal antibody drug. This gives promise for people who are not able to mount an immune response, such as those on chemotherapy for cancer, people with HIV, or transplant recipients, for example. But more work still needs to be done to confirm that. There is a new monoclonal antibody product that is applied for emergency use authorization from AstraZeneca, and at least in preliminary studies, this appears to be much more potent than the Lilly or Regeneron products, providing up to 90% protection from death and hospitalization. Again, small numbers of patients studied, requires confirmation, but very promising. And we know remdesivir, which is expensive and has limited utility, has been used with some success for moderate disease. I do want to point out another repurposed drug is in the pipeline. This is fluvoxamine. It's an antidepressant drug, or an SSRI. It has well-known anti-inflammatory effects. And there's a small early study that suggests that fluvoxamine which is inexpensive. A course of fluvoxamine could cost about $4, could prevent some hospitalizations and deaths. And my plea to everyone is let's not jump onto this or become advocates for fluvoxamine until the scientific process plays out. And I promise you that there are many well-designed trials underway to investigate this potential therapy for COVID-19. And then other exciting news, more traditional oral antiviral agents for early disease are being investigated. Molnupiravir is a polymerase inhibitor that was developed by Merck and Ridgeback. They've requested emergency use authorization, and this is going to be taken up by the FDA Advisory Committee on November 30th. And in early preliminary studies with about 2,000 patients, molnupiravir was shown to reduce the risk of hospitalization and death by about 50%. Even more exciting, Pfizer has a product called Paxlovid, which just completed a small phase 3 trial of about 700 patients that suggests that if given early in the course of treatment, may reduce hospitalization and death by up to 90%. And there are others in the pipeline. There's a Roche product called AT527 that is in phase 3 trials that may provide some promise for us. So looking to the future, we may have more tools in our toolbox than we've had recently. And these are all important components of helping us to get from pandemic to endemic for COVID-19. And next slide, please. Now, I'm not going to talk about these, but I do want people to know that we've been working on some simple talking points and information for parents who are trying to make the deeply personal decision about whether to vaccinate their children ages 5 to 11 for COVID-19. As you know, Pfizer received emergency use authorization for a low-dose formulation for kids 5 to 11. A relatively small set of kids, 3,100 kids were studied in the vaccine trials, and there seemed to be no serious side effects that were detected early in the study. And just like for adults, it's given in 2 doses 3 weeks apart. But again, I think even though kids can get COVID-19, they can die from it, they can have long COVID just like adults can. We know that they're less likely to have serious disease than adults. And so parents really need to have this information to make good decisions. And as we know, even in adults, there are serious side effects that can happen with COVID-19 vaccines. These generally are very rare, on the order of 1 in 10,000 to 1 in a million. But as you can see, only 3,100 kids were studied in this age group. So, there may be some questions that parents want to ask their pediatrician or family medicine doctor about the safety and efficacy of the vaccines. But we did find that these vaccines were quite effective in preventing COVID-19 in kids 5 to 11 on the order of about 90%. And with that, I'll turn it back over to Tim and invite anyone that wants to check out some of the talking points and information about vaccines for kids to download the handout.
Thanks again, Dr. Raymond. Lots of questions to start, but maybe one to start with in some of the data that you presented earlier. Do you have a sense when the state reports its data, how many people are showing up that have been vaccinated versus unvaccinated? Yeah, it's about 90% unvaccinated, at least in terms of severe disease. And let's also just be clear, there is very, very good data that suggests that you still get very good protection from getting even mild COVID-19 on the order of 6 to 8-fold improvements. And that if you are fully vaccinated and get COVID-19, that you're less likely to pass it on to others. But the vaccine doesn't provide 100% protection. There's nothing in medicine that's 100%. That's why we still recommend some mitigation measures for people that are going to be interacting with large numbers of folks outside the household. But again, great. The message is the vaccines give you outstanding protection. In terms of death and hospitalizations,
it's greater than 90% protection. More than 90% of the people being hospitalized with severe COVID right now are still unvaccinated.
Yep. And so the point is, and I get this question a lot, well, why get vaccinated if I can still get it? And so to your point, it's not a impenetrable shield, but it's much better protection than walking around without one.
Right. Why do we have airbags in cars? It protects you, but it's not perfect. You can still die in an auto accident, even with airbags.
And a couple questions around the vaccination for children and as families are dealing with this, and on one end, the question is, why so much pressure to vaccinate children when we don't have information on long-term effects? And then the other side of the question is, do you see a time when we're just going to roll this into vaccinations like mumps, measles, rubella, and smallpox that kids generally get at an early age?
Well, let me answer the second question first. Yes, I think at some point there will be a movement to incorporate COVID-19 vaccines into the regular vaccinations that kids receive. It's very likely that adults will be recommended to have annual boosters, but we don't know that for sure. So those are likely to happen. I'm not sure about pressure. I think pediatricians and family medicine doctors, organized societies that care for kids have strongly come out and recommended the vaccination, because even though we know that kids are less likely to get severe disease from COVID-19, they can still have severe disease, they can die, and they can have long COVID that really puts them back just in terms of their ability to progress in school from fatigue, shortness of breath, brain fog. Those don't happen as often as they do in adults, maybe on the order of 10% instead of 30%, but those are significant considerations. And yes, I also recognize that, again, we're following a small number of kids, 5 to 11, have really not followed them for 12 to 24 months like you normally want to do. But we also have experience with adolescents who seem to be doing actually better than adults in terms of their ability to tolerate the vaccines.
Yeah, one of the questions that we've talked about over the past week, Dr. Raymond, is that as people who have been vaccinated are coming up on 6-7 months since they've had their vaccination. Can you share your thoughts now about kind of a booster, whether you should get the booster with the same company you got the original vaccine with, or how that works for folks that had the J&J?
Yeah, thank you, Tim. We do know that there is mounting evidence that the protection that you get from the vaccines diminishes a bit over time. And again, I'm focusing on the a bit part. The protection 6 months out from Moderna and Pfizer is still quite outstanding in terms of protecting you from death or from hospitalization. But there's the idea that over time that protection is going to diminish. And typically when you receive a booster or a second shot, like we'll say for shingles, you space those shots out more than 3 or 4 weeks apart. The reason that the regimens were designed for COVID-19 with a short interval was because we really were desperate to prove that vaccines work so that we could get them out and start protecting people. So it makes sense that you might need another shot a few months down the road. Again, I want to stress the protection that people have 6 months out from Pfizer and Moderna is still quite strong, but this is more of a prophylactic to try to protect people that are more likely to have bad side effects from COVID-19. So 65 and older, people who by nature of their work or living environment are exposed to a lot of COVID-19. Now, in terms of which booster to get, we know that the J&J shot, it's just a one shot, its immunity starts to decline after 2 months, not 6. And we also know that in some studies where they did what's called heterologous vaccination or mix and match, where they switched from either the J&J to a Moderna or Pfizer or vice versa, that the immune response that people get measured by antibodies after the J&J shot is better if you use an mRNA vaccine. So for the J&J, if you get a second J&J shot, your antibody levels go up by 4 to 8-fold. If you get a Pfizer or Moderna shot, they go up by 50 to 80-fold. So there's a much higher increase in antibodies. That doesn't necessarily mean that it's going to translate into better protection in the real world. Those are small, short-term studies in a test tube, but that they really, there really is good data that those boosters help. So the CDC says it doesn't matter for J&J, you should get a second shot. They're agnostic about which ones you should use. But there are a lot of people that are saying, look, if Moderna and Pfizer give me a 10 to 20-fold better boost in my antibodies, if I get that as my second shot after the J&J, I'm going to go with that. And that's certainly a reasonable idea.
Are vaccinated people more likely to be asymptomatic if they have COVID versus those not vaccinated?
They are. Again, people who've been vaccinated tend to have milder disease. So even if they have symptoms, that period of time in which they're symptomatic might not be as long, and the symptoms may not be as severe. And again, thinking about why do we wear masks, or why are we socially distancing after we're fully vaccinated? Really part of it is to protect people around you, because even though the likelihood that you're going to pass it on to other people is reduced, if you don't know you're sick, or you don't think you're very sick, you still could pass it on to other people.
You talked about some of the trials. Of the trials mentioned, which ones are US-based, driven by the CDC?
Really, none of them are driven by the CDC per se. They're all driven by a desire of the pharmaceutical companies or vaccine makers to have good data to present to the FDA and the CDC for approval. So many of these are multi-site trials that happen in many different countries, which again is a good idea. It's faster for you to be able to acquire patients. You can have a broader data set so that you know, depending on where people are in the pandemic, that the vaccine or the therapeutic works better. But many of these big trials have happened in Europe, South America, Asia, Africa, and the US simultaneously.
So one question you're asking is there a reticence in comparing and reporting the difference in the effectiveness between Moderna and Pfizer, as well as the difference in the speed in which they fade?
I actually think we should compare them at some point. I think the reticence is not to overinterpret early data based on relatively small data sets. Again, we're talking about 2,000 to 10,000 patients, comparing small numbers of events. Some of the trials, we were talking about molnupiravir, there were only 10 deaths in the placebo arm. So, you know, that's not something that you can hang your hat on as being true forever. You need that proof in the real world. So I think that's really hesitancy. You know, I would say, and again, this is just not my medical advice, just my scientific advice. I think it's perfectly reasonable if you're comparing a second shot after Johnson & Johnson to want to get an mRNA vaccine instead of the J&J second shot. Again, because based on the early data, it looks like the antibody levels that you get are much, much higher after the mRNA vaccines as a second shot.
Yeah.
Pfizer and Moderna, there's a little bit of a difference. It's probably dose related. Moderna's standard dose is 100 micrograms of messenger RNA, and Pfizer is only 30. So it may not be that one vaccine is better per se, it's just that you're getting a higher dose.
Yeah. What do we know so far, Dr. Raymond, about the long haulers? Is if you have COVID, are you less likely to be in that category than if you've had a vaccination than if you haven't?
Based on what we know now, yes. It does appear that vaccination protects people who get COVID from then moving on to long COVID. Quantifying that's going to be difficult because, again, these are relatively preliminary studies with relatively low numbers, but there does appear to be a measurable protective effect from long COVID. And Tim, one thing I need people to really think about, when we think about the bad effects of COVID-19, people focus a lot on the mortality, which is about 2% in the world for confirmed cases. We know that we're missing some of the cases. People aren't getting tested, especially the mild cases. So the infection fatality rate is probably less than 1%. It's in the 0.6 to 0.7% range. But a third of the people that get COVID have long-term symptoms, and some of them are debilitating. And every health system in this region now has a long COVID clinic, and they're packed. They're full of people. They're unhappy with their quality of life. They're not able to return to work, and they're looking for help. So when you factor in the risk of COVID, I think people really need to think a lot about long COVID.
Yeah. I don't know if this question was spurred by Aaron Rodgers' discussion about the potential impacts on reproductivity, but a question here from somebody who said they were told after getting their third Pfizer shot they shouldn't reproduce for 28 days. You talk a little bit about what you know about the impacts on reproductivity, both from the COVID shot and from getting COVID.
Right now, there's no evidence that these vaccines impair fertility in any way. And I'm not sure who said that they shouldn't reproduce for 28 days or why. That doesn't make sense to me, and I don't quite understand it. But what we do know is that COVID attacks blood vessels. And there are significant real reports of men having erectile dysfunction after a COVID-19 infection. And again, there's a scientific reason for it. COVID-19 attacks blood vessels. That makes perfect sense. So when you're doing a risk assessment, the evidence that COVID-19 itself causes problems either with erectile function or fertility is real. That risk from vaccinations is theoretical, and there really aren't good scientific hypotheses that would say why vaccine should cause infertility.
So I'm not sure if this question is also coming from a Packer fan, but do you think the 10-day quarantine period should be reduced, or does data show that people may not be as contagious as initially thought?
I think it's a great question. With the availability of rapid, inexpensive antigen tests, I think it's probably time to re-examine that 10-day period. And if people are infected, but they have, like in the NFL protocol, 2 consecutive negative tests spaced 24 hours apart, maybe they could end that quarantine. Do I think that will actually happen? I don't know, but it's perfectly reasonable.
Yeah. We've talked a little bit about this before. Can you also comment on the natural immunity that people get from COVID-19 and the inclination that they don't need a COVID-19 vaccine if they've actually had it?
Yeah. By natural immunity, which is a term I actually don't agree with, because every immune response we have is a natural immune response to some provocation or an antigen. But anyway, this is referred to as the immunity you have after a COVID-19 infection. It's actually pretty good. It's inconsistent. We believe that vaccine-induced immunity, with the notable exceptions of people that are immunocompromised, is more consistent. And there have been some comparative studies. The one that people that don't want to be vaccinated talk about is a natural history study in Israel. But there is a US study that was recently released by the CDC that showed that vaccine immunity was better, just in terms of protecting. But what I would say right now is it's an open question. But what we do know is the people who end up with the strongest immune response are folks that had COVID-19 and then got vaccinated. That seems to give you the strongest immunity. And we also know that people who get COVID can be reinfected and they can die from their reinfection. And this shouldn't be news to anyone. Back last year when the P1 variant was circulating in South America, a lot of the people that were sick from P1 and died had already had COVID-19 from the original strain. And so there already was real world data from South America that suggested that some of these variants could reinfect and could still kill people after they had a COVID infection.
Let me ask you this kind of as a summary question on some others that have come in. If you look at, you know, the Pfizer, Moderna, or J&J, the vaccines that are out there, as we term them, the jab in the arm, is there an alternative way of protecting yourself outside of the vaccine that you would recommend?
Let me first acknowledge that anything you can do to keep yourself in good condition and quote unquote prime your immune system can help you, but there is no substitute for the immunity that you get either from vaccination or a previous COVID-19 infection. The homeopathic remedies, nosodes and some other things people talk about, there may be some scientific basis for considering that they might work, but the real world data that they can substitute for vaccination is completely lacking. And I would just say that there is no alternative to vaccination. Now, one caveat, again, gets back to what Regeneron said. Regeneron and all these monoclonal antibody cocktails are synthetic antibodies that are manufactured and then injected to really reconstitute your immune response. It may be that a subcutaneous shot with this Regeneron monoclonal antibody cocktail could give you immunity for up to 6 to 8 months based on that very preliminary study that was reduced and needs to be confirmed. So I don't want to say that there's no possibility that we could ever have a substitute for vaccination, but right now, despite the popularity on social media and a lot of strong advocates, these homeopathic vaccine alternates have not been proven to be effective.
What about the case where someone who has been vaccinated gets a breakthrough case? Should they get a booster?
You know, that's a really great question. And I don't think that there's a really good answer to that right now. There just isn't data out there. To be safe, I think most clinicians would say that when you're 4 to 6 weeks out from the breakthrough infection, you should get a booster. But that's just based on clinical intuition, and I think more work needs to be done.
And then, you know, another thought on this, I think that, you know, healthcare has up to this point been very personal. And I think part of the challenge is we're piercing some of that personal nature of healthcare. But as I've seen employers, and even in our own place, as we've come back to work, we've had a case where you have an employee that will come in for a day and then the next day text you and say, look, I just tested positive. I want you to know I'm sharing this information so other people that I may have come in contact with understand this. I think I'm seeing that become more and more the norm. But interested in your thoughts, Dr. Raymond, because this is part of the challenge here of just how personal healthcare has been to all of us and now how public it is.
Yeah, it's kind of a new world where you're balancing personal privacy and liberty concerns with social benefit, and that includes your coworkers and people in the same learning and living environment. And there's no right answer, and we're trying to work through all these details in the middle of a pandemic, unlike anything that we've seen for 102 years.
Yeah. And then a question here about, okay, I think we got that answered. Somebody was looking for information they could find on the vaccination for kids, but I think we've got them that information. Again, you've been super generous with your time. I appreciate, as always, the fact-forward responses to these questions that folks have as we continue to live with this. And I've stopped saying in the past, because you and I have discussed, Dr. Raymond, I think the pandemic is going to be with us in some form going forward. So we're going to have to evolve with the science and continue to learn. So I guess we'll end up with, you know, any closing thoughts you might have looking forward as we run into the holidays and as we look at how we're dealing with COVID-19 and some of the variants.
Yeah, thank you. Look, we're all isolated. We're tired and fatigued from COVID-19. We want to hear good news. What I would just encourage people to do is be as well informed as they can as we do come together with family and friends. For those who can afford it, there are rapid antigen tests that can make you feel a little bit safer, at least for 24 hours. If you interact with family and friends that are coming from other locations. But this may not be popular, but I'm just going to say, don't prematurely declare victory. We continue to do that, and it just makes it harder the next time that we have to isolate. But there's a lot of promise for the future. You know, as I mentioned, we're making progress on therapeutics. These vaccines are they're very efficacious, and they have a favorable safety profile. And you know, I think there's promise for the future.
So I got one more I'll squeeze in here, and then we'll wrap it up for you. And the question really goes to the healthcare systems. They're strained for talent, and most all of the healthcare systems have put this deadline on their employees to get vaccinated. Can you just comment on that? Because I know you're going through that in your own institution.
Yeah. Again, this is where personal liberty and personal beliefs about what science and trusted sources that people want to believe conflicts with what healthcare systems believe they need to do to have a safe working and clinical care environment, and a responsibility to the community to do everything you can to keep people safe when they come to you for care. And there's clearly a clash there. But despite all the concerns, and we do have a healthcare shortage, fewer than 1% of the healthcare workforce has either been terminated or has resigned over COVID-19. And in many cases, those are not frontline healthcare workers, but they're people that are support staff. So, you know, it is a concern. We've lost some people, but it's, you know, it's not a limiting factor. Again, it's less than 1% of the workforce. And that's been very consistent across the US.
Well, thank you. And again, Dr. Raymond, what I appreciate so much about this is it's hard to find a space in the community where you can actually have a conversation, not a shouting match. And this is a great place to have an informed conversation and share lots of different views and get some good answers. So again, we appreciate you joining us. We appreciate all the work from the Medical College of Wisconsin and your team, and look forward to connecting with you probably after the new year.
Thanks so much, Tim. Take care.